Greetings from Balaji Medical College, Chennai. This is Dr. Balakrishnan, Dr. Professor Balakrishnan, Professor of Ophthalmology and Unit 2 Chief of the Balaji Medical College, Department of Ophthalmology. Today we are discussing and speaking about the cataract treatments, complications, preventive measures, and all the things which is related to the cataract. Cataract is a disease which will produce dimness of vision and finally loss of vision, and it is the duty of the doctors, ophthalmologists, to prevent and treat the cataract blindness, either by initially there are many methods, but finally the ultimate treatment is the surgery. Now we are just starting the speech about the cataract. This slide, what you can see, definitely there is an opacification at the central part of the lens. The whole lens is somewhat very white, milky white. It is a picture of mature cataract. What is the cataract? Opacification of the lens and its capsule is called cataract. And what will happen if the cataract is formed due to the cloudiness? The vision will be gradually reduced, gradual progressive dimness of vision, finally loss of vision. And there are various stages of the cataract formation. Depending on the stage, the clinical symptoms, signs, visual acuity, so many other features will be there. What are the causes of the cataract? The preventable blindness. One of the major causes of the preventable blindness in the world is the cataract. And a good number of people, almost about 80 to 90% will have cataract, which should be operated in time. Otherwise that will lead to the blindness. And finally, the family will be affected, economy will be affected. And if you don't treat cataract, not only the vision is lost, but that cataract will produce complication, a lot of secondary glaucoma. And generally it is called as a cataract will be bursted. What are the causes of cataract? There are many causes. The congenital causes are there. Due to old age is there, and if there are certain diseases which will produce cataract, like diabetes, uveitis, and any previous trauma or instant trauma, cracker injury, previous ocular injury, also will produce cataract. Of course, these are certain medicine like steroids, phenothiazines. Prolonged use of this medicine also will produce cataract. If you get a trauma to the lens directly, within seconds it may form cataract. Maybe within after 1 or 2 days, the cataract will be developed and the vision will be lost totally. Congenital, so many causes. There are autosomal dominant, autosomal recessive, sporadic, and the idiopathic. The reason is unknown, idiopathic. And many times it will be inherited. It is running in the family. The cataract will start early in certain families. You see certain families, even at the age of 98, there is no cataract. And there are certain inherited abnormality, inherited diseases like myotonic dystrophy, Marfan syndrome, rubella, even high myopia. A patient who are suffering high myopia, even though it is a refractive error, they are prone for cataract development. The commonest cataract is the age-related cataract. Age. It can be classified as an anatomical classification. Suppose cataract comes in the nuclear area. It is called a nuclear cataract. Suppose it is affecting the cortex of the nucleus, not cortex of the lens, called cortical cataract. If it is affecting subcapsular area, subcapsular, anterior subcapsular, posterior subcapsular, and the Christmas tree, either depending on the anatomy of the opacification, there are various types of cataracts. And depending on the onset of cataract or the maturity of the cataract, we can again divide immature, mature, and hypermature. Hypermature cataract is various types. Morgagnin cataract is very particularly very important. There is a liquefaction of the lens. Then the central nucleus will be liquefied. That will be sunken in the liquefied cortex. It will be somewhat floating in the liquid of the cataract. And now you see the pictures. You can see the various types of cataract. You can see the nuclear cataract and the early spokes of the cataract coming from the sides of the lens. Posterior subcapsular cataract picture is there. The zonular, only particular area of the lens is covered, the zonular cataract. And the predicum appearance is there. Christmas tree type cataract is there. Because these various types of cataracts produced by either uveitis or diabetes mellitus or secondary cataract. So once the cataract is very much formed, the treatment is only surgery. Till the cataract become mature, there are some areas of the lens through which the light will be passed and the patient can see somewhat vision. And we can improve many times vision by doing a refraction. Suppose the sclerosis, the deposition of the opacification starts at the center of the nucleus, it is called a nuclear cataract. Suppose the opacification starts at the periphery, it is called cortical cataract. So depending on that, suppose cortical cataract will produce plus refraction, and if it is affecting the nucleus, it's a minus refraction. Let us speak about the history of treatment of the cataract. Several thousands of years ago, Susruta in India and some physician in Gulf countries, they have started one procedure called couching. It is a crude procedure. So it is nothing but by piercing the eye with a sharp instruments and pushing the lens from the central area of the eye. That is called couching. When the media, that central area is clear after removal of that opacified lens, suddenly patient can see something. Of course, there is a lot of complications. So that is the type of couching is nowhere practiced anywhere. Now the latest type of surgery is after that the easy extracapsular cataract extraction surgery was invented by Dr. Jacques Daviel 100 years ago or 100 years ago, but due to primitive nature of the visualization, there is no proper apparatus for visualization, no microscope, no suture, no instruments. That extracapsular is abandoned. Then a new method called intracapsular cataract extraction. What is the difference between extracapsular and intracapsular? Extracapsular, the lens has anterior capsule and posterior capsule. Anterior capsule, we are making a small hole and nucleus and cortical matter is removed. But the posterior capsule will be remaining there. That is ECC. But in the ICC, intracapsular cataract extraction, the whole lens along with the capsule is removed. There are advantages and disadvantages for the ICC. Advantages is there will never be a posterior capsular opacification because the capsule is not there. So what is the negative point in that? The patient has to wear approximately plus 10 thick glasses. It is called aphakic glasses. In Tamil it will be called as a soda body glass. So the ICC ruled the whole world for about 100 years without any challenge. After 100 years only, we have reformed our microscope, reformed our suture, reformed our instruments. So many viscoelastic material, lubricating drops, ointment, pilocarpine, adrenaline, so many medicines we have invented. And we have invented latest machine like phacoemulsification. Finally, we have reached femtosecond laser assisted phacoemulsifications. So extracapsular, we reinvented the ECC again. The evolution of the cataract surgery from couching to ECC, ICC, again ECC. The various types of ECCs there. One is small incision cataract surgery where manually the lens is removed through 5 millimeter incision. And this will be done where there is in villages, so many small towns, etc., primitive area, there is no phacoemulsification machines. So due to the lack of the machines, and SICS is a very good procedure with a good results. But the latest phacoemulsification is the number one surgery and best surgery. Of course, the latest version is the femtosecond laser assisted cataract surgery is the latest one, depending on the availability of the machines, surgical skill of the doctor, and depending on the paying capacity of the patients, patient can avail any type of surgery. Before surgery, what are things should be done? So we cannot take the patient directly to theater. So we have to prevent all side effects, preoperative, intraoperative, and post-operative complications of the cataract surgery. Of course, we should ask total complete history, symptoms, signs, and the patient has any associated diseases. We have to get a witness from the concerned specialist. After cataract surgery, we have to ensure good vision. If you want to ensure good vision, the retina, the visual pathway should be proper. We are just removing the cataracts, but the cornea should be normal, or visual pathway like aqueous humor should be proper, vitreous should be normal, retina, optic nerve, optic chiasma, optic radiation, and lateral geniculate body. Everything should be normal, visual cortex, and by perception, by finally the visual cortex will analyze the picture, images, whatever, and it will be come back to our minds, patient's minds. So the fundus should be examined properly, tonometry, that there should be proper intraocular pressure should be within normal, it should be less than 21 millimeter mercury. And we have to do indirect ophthalmoscopy to rule out any peripheral degeneration of the retina. Suppose patient is having mature cataracts and we cannot see the fundus because of the media hazy, then we have to use the B scan. B scan. So what is the difference between A scan and B scan? A scan one is unidimensional. A scan is used to calculate the intraocular lens power, axial length. But B scan will give the two-dimensional picture, and we can rule out any retinal detachment, vitreous hemorrhage, and so many other indirect tests. It is called retinal function tests. It should be done to rule out any retinal diseases. We have to ensure that after cataract surgery, patient will be getting some vision. And how can we calculate the intraocular lens power? It is using the biometry, SRK formula. We are basically using SRK formula, and with that two parameters, two things are required. One is the axial length. Second one is the keratometry value. That is the corneal curvature, K1 and K2. Axial length is measured with the help of biometer. Keratometry is done with the help of keratometer. Then finally, that SRK formula will give us what is the intraocular lens power for the particular patients. Pre-medication, and we have to, some patients are very anxious, we have to give some anti-anxiety medicines, pre-operative antibiotic drops, tablets should be given, and pre-medically before cataract surgery, all the medicines which patients continuing for diabetes, hypertension, any other diseases should be continued, should not be withdrawn. And where any surgery, when it is involving too much hemorrhage, we have to previously we have to stop, at least 5 days before clopulate and aspirin. And it is better to do Xylocan and bupivacaine. Sensitivity test is a skin test, and it will help us while giving infiltration anesthesia. Patients should not develop any allergic reactions. And of course, before starting surgery, previous day, we can clean the eye with soap, water, and betaine eye drops. One day earlier, on the day of surgery, we can again repeat the urine and blood examination to rule out diabetes, hypertension, and patient can undergo pulse oximeter use and BP apparatus, and we have to ensure that proper oxygen is there, and pulse rate and BP is normal. And specialist fitness is a must to prevent complications. And before cataract surgery, before any operation theater should be pakka. It should be properly cleaned and fumigated. It should be totally bacteria and fungus and virus free. Of course, that stage is over. Now, what is the next stage? What are the prerequisites in the operation theater? The gone era where there was no facility. Now, patients are demanding too much. Zero complication, zero side effects. That is our aim, that patient's aim, doctor's aim. So the operation theater should be fully equipped with the proper all instruments. So proper sterilization should be done properly. Then BP, pulse, oxygen, saturation, IV drip. Better start IV drip to all patients, even normal patients. So that even if anaphylaxis or something happens, we have to give all the important medicine. Oxygen, better start with the oxygen in the nose. And after that, we have to give topical or peribulbar anesthesia using the bupivacaine, 2% lidocaine. The doctor should be washed properly 3 times with normal soap, finally with the betadine scrub, and the area of the surgery, around the eye and the surrounding area should be painted with a betadine solution. And we have to use proper ocular stickers so that only we can visualize we can uncover the particular area for the operation. Proper draping should be done. And the procedure, depending on the procedure, what procedure we are going to do, either ICC, ECC, or SICS, small incision cataract surgery, or phacoemulsification, or femtosecond LASIK laser cataract surgery, and we have to do in a proper way. And all surgeries cannot be done in all cases. We have to understand that one. Patient also should know, suppose if cataract is very mature, hyper mature, grade 4, 5, etc., it's better to do conventional ECC. And if you try the laser surgery or phacoemulsification, a lot of complications due to that meddling and energy, like pseudophilic blood keratopathy. There will be endothelial loss and side neighboring tissues loss, a lot of complications. So such a situation, better do the classical ECC. The classical ECC, we have to make an incision from 10 to 12 millimeter. So because normal size of the lens is 10 millimeter. So we have to either that incision can be scleral or corneal. It can be Frauen or Chaurois. Astigmatism-free surgery. Even though we are using sutures, the incision should be nowadays not a direct entry into the cornea or entry into the sclera. It's a step by step. So 3 step. So it will produce a tunnel. It will tunnel. Even though no suture, it will be self-limiting. And any incision which is more than 5 millimeter, we have to apply suture. If it is less than 5 millimeter, the classical phacoemulsification, the incision size is 2.8 millimeter. Micro incision phacoemulsification, we can finish the phacoemulsification even through 1 millimeter or even 0.9 millimeter incision. But of course, after MICS, micro incision cataract surgery, the foldable lens, very small, that we have to little enlarge that point. The normal, the 2.8 millimeter for the phacoemulsification, we can conventionally available foldable lenses can pass through that or through the hole through injector. So SICS and phacoemulsification and micro incision cataract surgery, or it is a self-sealing incision. Suture is not at all required. ICC, intracapsular cataract surgery, is nowadays we are not at all using. But a certain situation when we are unable to do ICC, VCC, or is a phacoemulsification or any modified ECC due to subluxation of the lens, dislocation of the lens. Such a situation we have to resort to the old ICC. Cryo extraction is a standard method, even though tumbling method, modified Smith tumbling method is available. Once upon a time in the camp surgery, etc., we have done a lot of ICC using the modified Smith tumbling method. Now come to the latest surgery, that is none other than femtosecond laser assisted phacoemulsifications. What is the advantages? Here, infrared pulses are used. It can accurately see 3 micron level with a difference of 1 micrometer accuracy. That will produce air bubble formation, cavitation, that will separate the fibers of the cataract. So the femtosecond laser is used to make a small incision in the lens. It will make an incision in the capsule, that is capsular axis. It will divide the nucleus into 4, 5, 6 or whatever precisely. So we can reproducible, accurate, with the least complication, almost no complication at all. In femtosecond laser cataracts, there is a 2 procedure. One is, first patient will be taken to femtosecond laser room. The initial corneal incision, capsular axis, and lens cutting will be done there. Then patient is taken to another machine, that is phacoemulsification, normal phacoemulsification machine. So it's a two-step procedure. As I told you, the advantages of the femtosecond laser is the manual method is almost nil. So everything depending on the machine, and the laser is controlled and the digitalized. So more accuracy, less complication, and patients with complicated capsules, and patients with a very hard nucleus. The femtosecond laser assisted surgery is very easy, complication are less. It is superior over the classical phacoemulsification. Of course, phacoemulsification is a better option than ECC. ECC is a large incision, so the patient can take bath after 3 weeks, and the astigmatism, everything will be cleared after about 1.5 months. But in phacoemulsification and femtosecond laser phacoemulsification, and everything will be cleared within few days. Patient can have bath after 5 days, and the residual refractive error can be corrected immediately after just 1 or 2 weeks. So we have discussed about the various advantages of the phacoemulsification and femtosecond laser. What is the advantage of the ECC over ICC? As I told you, ICC advantage is that we never required YAG laser to remove that after cataract if you are doing ICC, because we are removing the lens along with the capsule. But in ECC and phacoemulsification, and 20 to 40% of the people can have posterior capsular opacification, secondary opacification, maybe within 1 month, maybe after 5 years, 6 years. So ICC, that will never happen because there is no capsule. What is the disadvantages of the modern surgery, phacoemulsification and femtosecond laser cataract surgery? It's very expensive. Machines is very expensive. Need more expertise. The expertise of doctors are very less. And the learning period for the surgery is more. But once we learn, that is a best procedure, best thing we can offer to all patients. This slide, you can see the femtosecond laser machine. You can see patient is taken to that machine initially and do that corneal incision, capsular excision, cutting of the lens. Then patient should be shifted to routine phacoemulsification machine. And in this chart, you can see the difference between the conventional cataract surgery and phacoemulsification. I have already discussed. What is again one step forward? That is none other than robotic femtoplastic laser. Now throughout the world, the research and everything is going on to already introduce robotic. The machines is controlling the surgery. The surgeon will not see the patient's eye directly, but rather than surgeon will see the laptop or screen and decide the various steps of surgery. What is the advantage of the robotic surgery? It's a very highly magnified view what a surgeon is seeing. So if you see the screen, highly magnified. If you see through the microscope or directly seeing the patients, the magnification is not that too much. There are chances for complication. But in the highly magnified robotic surgery, more precise, more accurate, we can see the thickness of the posterior capsule, we can see the distance between the cortical matter and the capsule and where we are putting lens, etc. That is the advantage. Even though it's costly, now the world is gradually turning towards that robotic femtosecond laser assisted cataract surgery. So this picture you see, this room, operation room, where phacoemulsification is done in our hospital. The team, sister, nurse, draped, and the patient's draped instruments are there. Of course, the phacoemulsification and femtosecond laser surgery and SICS is called as sutureless, no pain, because we are, most of the cases we are do under topical anesthesia, no pain, no injection, no stay, no pad. Pad will be given for few hours, maybe 1 hour. So patient will be going home with the glasses only. There is no patch, because the operation is done precisely with the machines and robotic instruments. So the complication is less. Pre-operative and intraoperative and post-operative complications are very, very minimal in the latest surgery. Now let us come to what is intraocular lens. What are the types of intraocular purpose? Is it necessary? Various types of lenses. Of course, unifocal, multifocal, accommodative lenses, and UV light lenses. So many lenses are now available in the market. It is imported lenses are available. Our indigenous lenses are available. And the lens has two parts basically, optic and haptic. One of our expectation, one hope, one promise is the accommodative lenses, even though not a perfect one available now, but it's not a perfect one. It has the side effects. Accommodative lenses. Once we do cataract surgery, the accommodation will be lost. But to reduce that disadvantages, accommodative lenses are available. Multifocal lenses. Why the accommodation is required? For the near vision only. So the multifocal lenses are available so that we can see the distant, intermediate, and near. Now, a type of lenses called in focus and related other companies. In that, we can see distant vision clearly, but near up to 1 meter. Even if you keep the object little away, we can see clearly. Even though reading glasses required, that in focus like lenses will provide better near vision. And in this slide, you can see various types of lenses. Various types of lenses available. You can see the yellow lenses, accommodative lenses, modified J, modified C loop, various types of optics, and multifocal lenses. And all lenses are not used in all cases. There are indications. Any patients who have retinal degeneration, retinal disease like diabetic retinopathy, hypertensive retinopathy, any other retinal disease, better we avoid multifocal lenses, because such patients will require frequent retinal investigation after cataract surgery. And multifocal lenses, there will be various rings are there. Fundus examination will be hampered if we are using multifocal lenses. Even normal patient who has no any side effects, complication, multifocal is advised. Otherwise, monofocal. And you see the next slide, how the lens is injected or folded into the eye of the patients. In this picture, in this slide, you can see foldable acrylic lens with the help of injector. And the lens will be folded. It will be pushed into an injector, and the injector will be the lens will be loaded into that injector, and with the help of viscoelastic The lens will be rolled, folded, and kept inside that lens, and it can be passed through even micro incision cataract surgery, 1 to 1.5 millimeter. Even such advantages are there. The classical phacoemulsification 2.8 millimeter. Now MICS, even 1 millimeter, the surgery will be finished. But if we little bit extend, we can see the MICS lenses can be injected. Why? We want a small incision. In a small incision, suture is not required. The rehabilitation, visual rehabilitation, and less astigmatism, less period for recovery, less complication, less infection. So all this leads to the invention of the small incision surgeries. Whenever the small incision, we need small particular lenses which can be folded and pushed through that. So we are our procedure to various instruments in the invention to find out the new lenses are still going on. Almost every year new lenses are available. Suppose people is not dilating. For one prerequisite for good cataract surgery is a good dilatation. Suppose people is not dilating due to many diseases. Again, for that there is a solution. We are using iris retractor. Iris retractor is nowadays. This is one method. There are so many other dilators are available in the market. This is simple and cheapest. What is there in this picture, in this slide? The application of the iris retractors. So it's a pulled. There are 5 retractors are applied in this slide. So the surgeon can do the surgery in a leisurely. As I told you earlier, before cataract surgery, we have to calculate intraocular lens power. For that, we have to do the keratometer. This slide, you can see the doctor is conducting keratometry. So vertical keratometry and horizontal keratometry, and the average will be taken. So we need axial length, the anteroposterior length of the IOL. For that we are using biometry. It is called B scan. It's A scan, biometry A scan. We want a single dimensional spike, one spike from the beginning of the cornea, another spike at the back of the retina. So by calculating the axial length and the curvature of the cornea, we are calculating the intraocular lens power. And we have to preview, before cataract surgery, so we have to assess what is the status of the retina. And we have to promise how much vision will be coming after cataract surgery. And we have to rule out retinal diseases. One method, the latest method is optical coherence tomography, OCT. It's nothing but a CT scan of the eye. Even though costly, now it is a compulsory, even all people are. So after cataract surgery, and we have to ensure good vision. A person with a good retina vision, we can advance, we can promise the vision, nice vision. As I told you earlier, suppose there's a full mature cataract, white cataract. We won't be able to, in mature cataract, we can see the retina fundus through the ophthalmoscope or indirect ophthalmoscope. We can do the fundus camera. But when it's a fully mature cataract, how do we know there is no retinal detachment, no vitreous hemorrhage? For that we are doing B scan. And with the B scan, it's a 2-dimensional phenomena. So we can see any vitreous hemorrhage, any retinal detachment, any foreign body, any abnormality. And if you want to record the retina in advance, patients who are suffering from diabetic retinopathy, any other retinopathy, anemic retinopathy, any AIDS-related complication, anemia, definitely a lot of changes and destruction will be there in the retina. That should be recorded with the help of fundus camera. We can do just to record that fundus, or we can do detailed study by using fundus fluorescein angiography, where the fluorescein medicine is injected through the vein. Within seconds it will be reaching the retina, we'll be taking series of photograph with the same camera, fundus camera. And in many times, suppose patient has already, there is a diabetic retinopathy, non-proliferative diabetic retinopathy, already damages, and we have to do certain treatment to the retina before cataract surgery. Otherwise, the cataract surgery itself will aggravate the diabetic retinopathy and retinal complications. So that we have, sometimes we have to do pan-retinal photocoagulation with argon laser. Sometimes we will be doing the grid laser, focal laser. We'll be destroying certain areas of the retina. Sometimes we'll be destroying the hemorrhages, X-rays, etc. Of course, intraocular pressure is very, very important. Before cataract surgery, a patient who has very high intraocular pressure, they are prone for many surgical complications like severe hemorrhages, expansive hemorrhages, like that. So before cataract surgery, we have to do tonometry. Tonometry is there are two types. One is applanation tonometry and another is shear tonometry. Applanation tonometry is superior. So now you learned about the various types of surgery, what are the side effects, what are the specific problems. Now, how can we prevent it? Can we prevent the cataract? Can we have some simple methods? Of course, there are certain methods, even though there is no any 100% preventive measures. But we can prevent many things. Because cataract is not only the age-related cataracts. There are so many other cataract related to the what is called diabetes, many other systemic diseases, drug intake, trauma. That should be prevented by using proper goggles, proper prevention. We can prevent the ultra UV light with proper glasses, goggles. And one etiology for the age-related cataracts is the diet. So we should have proper diet, having multivitamins, healthy lifestyle. And we can prevent a lot of diseases by giving immunization. When the mother gets some infection, the child will be born with cataract. We can prevent a lot of congenital cataract by giving immunization to the mother. And even after the birth of the child also, many immunization will prevent diseases which will produce cataract. Of course, now it's a modern era. Even poor patients should have the master health checkup facility. And every year they have to undergo the whole body checkup, abdominal scan, basic blood and urine investigation. And after the age of a particular age, especially after the age of 40, and everybody have to undergo the routine regular eye checkup every 6 months. Diabetic patients and hypertensive, so many other patients should better come for the glaucoma patients. They should come for the checkup almost every 3 months. With this is the last slide. And you see the pictures in that one. What are the preventive measures? Goggles, nutrition, prevention of the UV light. Thank you very much. So far we were discussing and you are hearing and seeing the cataract. What is the reasons for the cataract? What is the etiology? What is the classification? What are the preventive measures? What is the latest and what is the primitive earlier decades of ago? What was the treatment? What is the present latest treatment? That is femtosecond laser assisted Phacoemulsification cataract surgery is the latest surgery without any side effects, even though it is costly, but that is the ultimate surgery by predicting the best results. Of course, So many other methods are there. Simple phacoemulsification, ECC, and all surgeries are not suitable to everybody. That also you have to understand. So we are dealing with the patients, and normal patients, there is no any problem. But a patient with secondary diseases, any immunocompromised patients with cardiac problem, other things, we need the help of the other specialists. And body should be first fitness should be received, then we have to do surgery. In between surgery also something happens, and we need support of the anesthetist, neurologist, etc. That is only for the immunocompromised and challenging patients. So you heard that the preventive measures. So thank you very much for listening and hearing. So thank you very much.